Global Conference on Post-Pandemic Reforms in Medical Education for Accessible and Affordable Rural Healthcare. Technical Session 3 will focus on examining the role of values-based medical education on compassionate, equitable, and inclusive healthcare, and examine how technological advances and medical services are received by the community based on their narratives, value judgments, traditional values, and cultural norms. The co-chairs for this session are Dr. Jorge Luis Berra, Ayurvedic physician from Argentina, and Dr. Hiramalini Shashadri, senior rheumatologist from Sri Sathya Sai Sarla Memorial Hospital. We now request the session chairs to commence the discussion. Over to you both.
Namaste, everyone. We begin now this session on acceptability of medical education, which only means accepting changes that are desirable in the right manner and at the right time. Our first speaker will address us virtually. She is Dr. Mimi Guarneri, the founder-president of the Academy of Integral Health and Medicine in San Diego, USA. She's board certified in internal medicine, cardiology, and nuclear imaging. Over to Dr. Mimi.
Hi, I'm Dr. Mimi Guarneri, and I'd like to thank Dr. Anand for the opportunity to talk about our experience with integrative health and medicine education at the Academy of Integrative Health and Medicine. I began my career in cardiology working on diseased coronary arteries, honestly not recognizing the importance of lifestyle change. In the 90s, my whole focus was to find tools that would help me to open up blocked coronary arteries, and for many years this was my work. One of the fundamental things I learned is that Western medicine is extremely strong in certain areas such as acute care, diagnostics, trauma care, and surgery. But at the same time, I learned that we are extremely poor in the areas of creating health and preventing disease. Our approach is one that's been accepted as a poly-pill for poly-ills approach, where every disease has a medication that's ascribed to it. We end up working in silos with clinicians often only focusing on their primary area of concern, whether it's rheumatology or pulmonology. Not only do we need a new model of training, we need a new model of approaching the human body. The pharmaceutical industry, at least in the United States, takes up most of our gross domestic product more than any other healthcare issue. Yet despite all of the money that we spend, we are still struggling with diseases that are completely preventable. 3 in 10 deaths globally from cardiovascular disease, according to the World Health Organization. 1 in 10 adults with diabetes, 422 million people, and rising, with the data increasing daily. Of course, we have millions of children under the age of 5 dying from diseases, again, that are completely preventable. Maternity health is another area where there's a big gap between rich and poor nations, and again, another area that is ripe for change and education. And mental health, particularly with COVID, has risen to one of the top areas of concern, whether it's anxiety or depression. We know over 300 million people worldwide suffer from depression, and we also know that a majority of these people are not being treated, less than 50%. Climate change poses another threat, and it is perhaps our greatest opportunity, but also our greatest health threat. and we're not meeting the demand right now. I presented at the Vatican a number of years ago, linking climate change and the choices that we make from what we subsidize to KFOS farming, having an impact on greenhouse gases having an impact on human health, and we historically turn to the pharmaceutical companies and hospitals, which have a huge healthcare climate emissions footprint. The end result is we're not getting to the underlying cause of the problems. COVID-19 became a game changer in many countries, and I will speak for the United States. We saw people with disabilities, we saw people that had underlying medical problems, people with behavioral disorders, racial minorities, ethnic minorities, tribal communities suffering the most from this pandemic. What we realized with COVID, and hopefully the world realized, that the people who had the less well-being, the people who were the least healthy, who had the least determinants of health, proper nutrition, restorative sleep, smoking cigarettes, stress, depression, loneliness, and so on, were the ones most likely to get sick. We know that the health challenges that increase susceptibility range from inflammatory diseases, which are preventable by and large, like heart disease, diabetes, hypertension, obesity, tobacco use, to people that are immunocompromised, and to people that have genetic diseases such as sickle cell. Right next to the recognition that COVID outcomes would be improved if we improve people's health outcomes is the concept of burnout amongst clinicians. So not only do you have a sicker population of people, you have clinician burnout. In 2016, clinicians reported burnout from too many hours at work, bureaucratic tasks, not feeling like they were part of a healthcare team that was appreciated. Many clinicians report not being satisfied with their life and their job. This is 2019 data showing overall dissatisfaction up to about 40%, 58% saying they're satisfied. Conditions of life are excellent, only 49%. Close to my ideal life, only 41%. Clinicians are not taking care of themselves. As you can see here, if you look at something as simple as exercise, only 10% are exercising every day, and approximately 50% less exercise less than once a week. If we look at mind-body practices such as mindfulness or meditation, 58% have no mind-body practice. COVID-19 and physician burnout has resulted in not only loss of physicians in the healthcare workforce, but loss of nurses, respiratory therapists, LVNs, and so on. But 89% of physicians reported depression. 53% said that depression is affecting their work, their interaction with their patients. 13% have thought about committing suicide. 35% felt that the administration has done very little to alleviate their burnout. Many started to have burnout before the pandemic, and it's only gotten worse. And happiness amongst physicians has dropped from 69% to 49%. So we need a new model of education and a new model of healthcare. Thomas Edison said the doctor of the future will give no medicine what will interest her or his patients in the care of the human frame, in a proper diet, and the cause and prevention of disease. And we have to remember that the best way to predict the future is to create it. So at the Academy of Integrative Health and Medicine, we have taken on all of these issues. We have taken on clinician wellness, clinician leadership. We have done this through summits, annual and biannual conferences, online learning, and fellowship training. We firmly believe that you cannot transform the healthcare system if you do not change the way practitioners are trained. In 2014, in the United States, the American Board of Physician Specialties recognized integrative medicine as a formal specialty with board certification, and this has been a game changer. The American Board of Integrative Medicine recognizes the Academy's review course for board certification. This is one of the few things that we do at the Academy of Integrative Health and Medicine. Our signature program is our fellowship. It is a 1,000-hour training program that is online with virtual retreats and some clinical immersion. It spans over a 2-year time frame, and it transforms clinicians into integrative health providers. And our fellowship allows for clinicians that want to sit for the board certification exam for integrative medicine specialty. We have a full-time dedicated fellowship team under the medical leadership of Dr. Erica Capilouti, who is a board-certified pulmonologist and board-certified integrative medicine practitioner. Our fellowship is not limited to MDs and DOs. We have been training naturopathic doctors, chiropractors, physician's assistants, nurse practitioners, physical therapists, licensed acupuncturists, Ayurveda clinicians, dietitians, dentists, and the list goes on, PharmDs, and so on, psychologists. Having everyone training together is a game changer for the future. If we don't train together, we can't work together. We have had multiple countries represented, including Colombia, Brazil, India, Turkey, Finland, Spain, France, Canada, and China. Our curriculum is very in-depth. It consists of clinical immersions and self-studies. Integrative disease management is 28% of the program, 100 hours on nutrition, mind-body therapies, over 90 hours, the business of integrative medicine, spirituality, traditional healthcare systems, and so on. This fellowship creates a foundation for integrative health and medicine leadership and training. It also is a foundation for a series of new certifications that the Academy will be certificates that the Academy will be launching. I won't read you all of these, but there are 8 blocks, 12 weeks, with 3 retreats, self-study options, and many people choose also to do a clinical immersion at our center in La Jolla called Pacific Pearl La Jolla to get that hands-on experience of integrative medicine. We have a terrific platform with a dashboard and Canvas. It's easy to use. People can study when they want to study, and people have the option of connecting with our expert faculty, fellows, and of course the AIHM staff. We believe that retreats are part of the healer process. This is a sample of one of our retreats, just a sample day. And I'll share with you a retreat that's open to everyone, which will be happening in January of 2023. Our online learning, our fellowship program is online learning. People do come together for clinical immersion if they choose to, and we have made a commitment, a big commitment to scholarship those who cannot afford the fellowship. We have given over $1 million in scholarship. It is the most cost-effective fellowship of all those that are available. This is what our fellows are saying. I'm happier in my practice. I've been more positive in my daily life. Patients are saying that they appreciate their clinicians better, that their clinicians are listening to them, and our clinicians are saying, I listen better to my patients. I'm more holistic. I'm more compassionate. This is just a small sample of what we hear. We offer online learning to anyone who wants to come on board. You can go to aihm.org and click on our learning portal. We have robust online learning that goes from our annual conferences to individual areas such as opioid crisis and mental health, environmental medicine, and so on. I hope that some of you may consider joining us for our AIHM 2022 conference, which is Disruptive Innovation and the Future of Health. This will be happening in San Diego, California in October 28th to 30th of 2022, with pre-cons beginning on the 27th. The conference is both in person and virtual, and if you need a scholarship, please let us know. Healing the Healer, Cultivating Resilience in Healthcare will be launched in January of 2023. So as an academy, as the Academy of Integrative Health and Medicine, we are working daily to transform health and medicine, particularly following the COVID crisis, to recognize the interaction between human health and planetary health, to train clinicians to think beyond what they learned in medical, nursing, PharmD, acupuncture school, to work together to create interprofessional relationships that ultimately lead to transformation in health for our patients and for the healthcare system, and to importantly recognize that it is fundamentally important to heal those that are doing the healer. We need to have programs all over the world to help with clinician burnout. Thank you so much for this opportunity. I can be reached at my website, and I'm happy to share anything further via email if someone is interested. Thank you.
Thank you so much, Dr. Mimi Guarneri. Thanks for your very interesting information about what this topic is done in USA. Our next speaker is Dr. Sri Krishna Rajagopala. He is the head of the Department of Camarability, which it means pediatrics in Ayurveda, and he is currently working at All India Institute of Ayurveda, New Delhi. He will speak us about academic experience of the integration of Ayurveda and modern medicine at All India Institute of Ayurveda.
Good morning to all. I'm taking you all to a different arena, that is our traditional medicine of Ayurveda and its strengths, and integrative medicine. My presentation will be having three major components: the academic experiences and integration, Ayurveda and modern medicine, and a glimpse of activities at my institute, that is All India Institute of Ayurveda. Friends, Tattva, Shastra and Vyavahara, these are the three things which makes every activity complete. Tattva means the principles, Shastra are the theories, and Vyavahara are the practice. Theories never change. Hypotheses can change, but theories are permanent, and theories are based upon the principles and Tattva. We have a strong heritage of Vedic literature and other literatures which give us a strong evidence, strong base for our Tattva and Shastra, including Ayurveda. And Vyavahara may vary from place to place, country to country, person to person. The modification in Vyavahara is what we require, and that is where we need integration. If you see the medical systems in the world, practicing medical systems in the world, the first ever well-documented, well-structured medical system, traditional medical system, if you see, it is Ayurveda. 2,500 to 3,000 years ago, when the first book of medical science was written, that is Charaka Samhita, it has recognized 8 different clinical specialities. The shloka goes like this: Kaya Bala Grahor Duanga Shalya Damstra Jara Vrushehi. Internal medicine, surgery, eye, ENT and dentistry, toxicology, pediatrics, gerontology or aphrodisiacs, and rejuvenative medicine. Along with that, applied psychiatry is also there. These are the 8 different clinical branches of Ayurveda. Of course, now because of the need of the hour, additional branches have been added which are supportive to all these 8 clinical branches. My previous speaker has already mentioned the strength areas of Western medicine, that is emergency care, surgical management, accident and trauma care, infection infestations, life-saving measures. Yes, The modern medicine is very strong in this, using the technology and science time to time. But when it comes to the cause of NCDs, non-communicable diseases, lifestyle disorders, and prevention, there are limitations. It is where the traditional medicines help. It is where Ayurveda helps. The very first chapters of Ayurveda book starts with the definition of health and followed by Dinacharya and Rutucharya, that is healthy practices to maintain healthy life. This is what we have to include in our medical curriculum. See, integration is required. Where? At the level of knowledge, at the level of practice, and to further fortify it, research and development. This is what you can see in our institute, as well as this is what the need of the hour. Integration at the level of knowledge. Of course, when I speak of the curriculum and syllabi of modern medicine and traditional medicines, I will concentrate on Ayurveda particularly. We have 4.5 years of teaching program and 1 year of internship program, wherein the initial first year is contributed to the basic sciences, where our students learn Ayurveda, physiology, anatomy, and fundamentals. Fundamentals, of course, is pure Ayurveda, and it is in Sanskrit based upon the darshanas. Whereas anatomy and physiology, it is the same human body we are studying, Western medicine, Indian medicine, whatever it is. So more than 50% of anatomy is modern, more than 40% of physiology is Ayurveda, the rest is combined together. We learn from Gray's Anatomy, we learn from physiology, guidance physiology, all other books we refer. So integration starts here in the Ayurveda education. Similar in the paramedical subjects as well as the clinical subjects. Whereas the Western medical curriculum do not have any traditional medicine in it. Now, of course, because of a lot of research and development in yoga sciences, some of the physiology books have some chapters on yoga, its impact on respiratory system, its impact on cardiovascular system likewise. But otherwise, there is no introduction of traditional medicines to the modern graduates. This is what is required. And it cannot be done in a day or two. We have to do sensitization first, then we have to do integration at the level of practices in some specialities initially, and research and development and avenues for further studies. So the Niti Ayoga of Government of India is introducing this. The new NCM based curriculum has introduction of traditional medicines. Every medical college in India is supposed to have one department of integrative medicine, one department of Indian systems of medicine. Let it be Ayurveda, Siddha, homeopathy, Unani, or yoga, whatever it is. So integration to be done at 3 different levels. So what we proposed to Niti Ayoga was a sensitization program, at least 15 hours of teaching on traditional medicines in the modern curriculum, and wherever in Ayush sector modern system introduction is not there, that has to be introduced. Then we can have special tailor-made programs and integration research. Of course, they need basics of biostatistics and research methodology. That has to be introduced. It has been already introduced into Ayurveda curriculum. Finally, students, they study biostatistics and research methodology. This is what I'm telling. Short-term courses and long-term courses and elective programs are the need of the hour. Now coming to my institute from where I'm representing, it's an institute under the Ministry of Ayush, an autonomous body, an institution of to be national importance and deemed university. It's in the headquarters, Delhi. A 200-bedded hospital we have, which is a tertiary care, holistic healthcare facility with all modern amenities. It's recognized by National Board of Hospital Accreditation, that is NABH, and it was officially donated by our Honorable Prime Minister in 2017. The footfall in our hospital, OPD, is something around 1,500 to 2,000 patients a day. And we have academic programs, only postgraduate and postdoctoral programs we have. We are affiliated to Delhi University, one of the central universities of India. And there are specialities, 12 different specialities of Ayurveda we offer programs. In addition to this, Ayurveda says that success of practice depends on 4 major things. One is Bhishak, the physician. Second is Dravya, the medicaments. Third is the Anustata, that is the nursing or supportive staff. And fourth is the patient himself. So we have to have success of treatment depends on supportive staff. We have skill development programs. Panchakarma and Kshara Sutra are 2 unique areas of Ayurveda which helps a lot in the present medical healthcare. And we have training programs for Panchakarma technicians, we have training program for Kshara Sutra technicians. In addition to that, of course, supportive like hospital administration and other. All teaching facilities like teaching laboratories, state-of-art laboratories are available with us, like pharmacology, pharmacognosy, pharmaceutical chemistry, drug standardization, language lab. This is unique for us because all our literatures are in Sanskrit and students are not exposed to Sanskrit language uniformly. So we have a language lab also. Going to the hospital facilities we have, which is truly integrative in nature. The name what you are seeing here, Kaya Chikitsa, Stri Roga, Kaumarvati, these are all Sanskrit names taken from the textbooks of Ayurveda. The English equivalents are given on the brackets. In addition to that, yoga, lifestyle, and diet clinic is also available. This is earlier. The beauty of our hospital or facility is we have an integrative unit. Integrative Ayush clinics, that is integration within Ayush systems. As you know well, Ayush, A-Y-U-S-H, it stands for the traditional practices of India, Ayurveda, Unani, Homeopathy, Siddha, and Yoga. Of course, now the Sova Rigpa, which is a practice of Tibetan medicine, it's also added to this. In addition to integration within the Ayush systems, we have integration outside Ayush, that is the modern medical practice. We have emergency medical unit. Wherever there is emergency, we take help of life-saving measures from the modern medicine. We have qualified persons with us. It is not that Ayush practitioners are doing the modern, but our students, our scholars are exposed to emergency care so that tomorrow they will be able to handle the emergencies or at least to refer the emergencies to the right place. We have integrative oncology, the data which I am going to show you. Integrative dental clinic, where all dental procedures are done as per the dentistry, dental sciences. Our scholars are helping there, and medication will be 90% Ayurveda. We have integrated orthopedic clinic, where I would like to share one of my experience. I had a patient of osteomalacia, a child of around 8 years of age, in the tibia. She had osteomalacia of long standing. She was operated twice. It had recurrence, and they came to us. We refer the case to our orthopedic. We have a good orthopedician, a retired professor from one of the renowned medical colleges of Delhi, like-minded professor. He examined the case and he said, whatever to be done, it has been done. Now cicatrization, the dead tissues are to be removed. Rest you do. He cleaned the wound and referred the patient to me. We treated with the Ayurveda line of treatment, Dushta Vrana Chikitsa. The concepts were followed, and today the wound is healed. The modern medicine, what is required, he has done. The Ayurveda management, what is required, we have done. The patient is healthy. This is what the ultimate goal. So many such experiences are there. We have a blood bank, radiology unit. We use all modern gadgets of diagnostics in Ayurveda management. Diagnosis through Ayurveda with the help of modern gadgets. In addition to that, COVID has taught us a lot of lessons. We have a COVID testing center, we have COVID vaccination center, we have COVID call center, we have COVID health center. In our COVID health center, we have treated more than 600 patients of mild to moderate COVID infection. In the initial days, we had to refer some cases to higher center for intensive care. Later in the second phase of COVID, we received ventilators. We started our ICU with the help of intensivist, and then onwards we have not referred. Even moderate cases never go on to severity. The treatment was Ayurveda. This is integrative oncology data. Every Friday we have oncology OPD, and we have a team of our board of doctors, integrative practitioners together, and we receive at least 30 to 40 patients in every OPD with a very good success rate, which has led to opening of Ayurveda unit at National Institute of Cancer, a part of All Indian Institute of Medical Sciences at Jajjar, Haryana, near to Delhi. Similarly, we have allergy respiratory clinic. We have developed herbal aerosols. Very good success rate we can see here. The multi-drug resistant tuberculosis, such patients also we are able to give good care. This is the diabetic and metabolic care unit where diabetic patients are there. Diabetic patients, you can see the gold standard of investigation, HbA1c, that also can be brought down with the integrative approach. Coming to the COVID, our activities were under 4 headings: academics, hospital services, public health, and media outreach programs. We had conducted one of the largest outreach program webinar where more than 1 lakh shots were there. And along with that, of course, sensitization programs were also conducted. The continuous activity of Havana, of fire offering, Homa, in the hospital, even today it is continuing for its antimicrobial benefits. This is the data of the hospital which I was talking about. More than 660 patients were admitted, and 99% of the patients were treated with Ayurveda intervention, and mortality rate is 0. Morbidity rate, of course, we could control very successfully. This is a vaccination report, of course, a passing reference. More than 50,000 vaccines we have given at our center. And this is the kit we had developed during the COVID period. One is Ayuraksha kit, which comprises of 4 units, different drugs, and another is Balaraksha kit for the children. It comprises again of 4 drugs. There is one drug which is called as Anutaila, which is an oil which has to be instilled to the nostrils. And this acts as a biofilm or barrier for the entry of microorganisms. It has been proved experimentally too. This is one of the exploratory studies we conducted in the largest population. 80,000 Delhi police personnel were treated with Ayurveda intervention. Preventive healthcare we have given here. And when compared to other metropolitan cities of India, the morbidity rate in Delhi police was very minimum. The credit goes to Ayuraksha. Using technology in learning and resources, we have started Ayur Informatics Lab. This picture shows one of the oil preparation which I use in my pediatric practice, Panchendriya Vardhana Taila. And you can see molecular docking mechanism we have used in. Synergies can be seen in multiple drug polyherbal combination too. The wisdom of ancient seas you can visualize here. This is the holistic approach, integrative approach required, whether it is Ayurveda, allopathy, homeopathy, whatever it may be. We should treat mind, body, and soul together. And with the help of medicine, with the help of diet, it can be rejuvenative drugs or certain biopurificatory procedures like Panchakarma or Shadkriya of yoga, whatever it is. Treatment should be holistic and to all. These are the strength areas of Ayurveda where we can contribute in the integrative healthcare. Total healthcare facility can be provided. Neuromuscular, musculoskeletal, degenerative, mental disorders, chronic diseases. These are all the areas where traditional medicines of India can help. So it's a yoga. I have shown only yoga and Ayurveda here. If it is not yoga, Ayurveda alone, all the medical systems are like 2 sides of a coin or parts of hexagon. If one part is lost, it will be incomplete. If everything is there, we can go together for the betterment of community health. So tomorrow's medicine is one medicine, that is integrative medicine. Thank you very much. Thanks to the organizers for giving me opportunity to present my institute before you, an integral part of integrative medicine. Thank you very much.
Thank you so much, Dr. Rajagopala. I just want to say I have the privilege to be at All Institute of Ayurveda, and I want to share the words from the General Director of WHO, Dr. Tedros Ghebreyesus. He said, I wish that all traditional hospitals has this kind of infrastructures that has All Institute of Ayurveda combining all the modern equipments with all the traditional knowledge. Thank you so much for your very good presentation.
And now we move from the ancient to the ultra-modern. We have Professor Dr. Kannan Maudgalya from IIT Mumbai, and he will tell us why we need to be ready to accept technology to improve medical education and healthcare delivery. Over to you, Dr. Kannan.
Good morning. Thank you for giving me this opportunity to make this presentation. And the title of my talk is Technology for Inexpensive and Effective Medical Education, more or less based on some of the things that we are practicing at IIT Bombay. So this is the outline of my talk. I'm going to talk about asynchronous technology that we developed, and then how we can embed it in software to make it a problem-solving solution. and then large-scale training through, once again, something that we developed at IIT Bombay. So I would like to begin with pedagogy for national level training. These are some of the requirements. Content should be suitable for self-learning, should be available in local languages, should be available at any time, anywhere, should be freely available, and should not demand too much bandwidth. That's an important thing that we discovered during the pandemic when people were trying to download and many people were left out. The instructional material that we create should be of good quality. So, for example, if we make an ordinary video, 10 people will watch it, but if only I make it 10 times better, 10,000 people will watch it. So it is worth investing that extra effort to make the content extremely good. So I believe that it is possible to use videos to reduce the resource requirements. Watch a video, people will say, how can a video replace actual hands-on? Yes, it cannot. Use it, go through a video, immediately after that, go and handle the real equipment, make a one-to-one correspondence. Next time you see the video, you will imagine that machine. It's all in our mind. So do the experiment with real objects. Learners can make one-to-one connection between reality and video, repeat it if required. The meaning of video better understood. After this, watching videos could be sufficient on many other topics. Resource requirement can be reduced to a fraction. So with the same equipment, you can actually, because the students don't have to go through all the physical equipment. Many of them they can go through videos and achieve. And I believe that if not to 1/10, at least 1/4 can be done. That is, same equipment can be used for 4 times the number of people at the minimum, I would believe. We came up with this instructional methodology called spoken tutorial. I called it spoken tutorial because you will not see the person's face, you will see the person talking. We created this started doing it in the year 2007, 2008 timeframe, when there were many silent videos, whereas all ours had a running commentary. So I said ours is spoken. There is another reason, as you see in the next one, our tutorials are dubbed into all our 22 languages. As a result, the spoken word is extremely important, so we called it spoken tutorial. As I already mentioned, these are usable offline, so it is possible to, for example, to conduct a training for all the people here. There are maybe more than 500 people here. All of them can be, just imagine giving bandwidth to every one of you here. If every one of you were to stream a separate video, different video, simultaneously, you don't have a big enough pipe. Whereas our method can be used for offline use. We trained 7 million students on IT topics in the last 10 years, and we extended it to health education. I put the created for self-learning in blue because that is the most important thing. So I have a few more slides on that. How do we design it? We write a script. We got this idea from movie industry. We have Bollywood. We have South Indian movies are doing extremely well lately. They all say, you might have heard the director saying, I had a great script. I decided to make a movie. Okay? A producer saying the same thing, of course, he will hope to make a lot of money out of that. In our method, we wanted people to understand. Remember making it 10 times better so that 10,000 people will watch it? We write the script. The script is written by an expert, usually. But it has to be used by a beginner who is not an expert. So that is where the mismatch is. So we ask the question, can a beginner understand? And most of the time, the answer is no. So we say, go and improve the script, because the beginner is my audience. He is my client. It should be suitable for her. It goes into the loop many times. In fact, the very first tutorial, I asked my manager to do 30 times because I wasn't happy. I was learning. She was also learning. But every time, she would smile and say, yes, sir, I'll do it. Of course, now we have developed suitable methods, so it doesn't take more than 2-3 iterations. Most of the time, it came out of the loop, and we record videos using these scripts. Videos created, as explained the previous page, are called spoken tutorials.
Welcome to the spoken tutorial on junk food. In this tutorial, we will learn about contents of junk food and harmful effects of junk food on.
Okay, that is a sample tutorial. My staff member said, it is too boring. You explain everything. I hate it. I said, let's find out. So we conducted a survey for people who use this. My people don't use it. They know everything, right? But the whole country needs. So we said, how many of you find it boring? We found that about 20,000 of the people, 25,000, 24,000 of the people said, neutral, interesting, extremely interesting. When I was a child, I always used to say, oh, I like the teacher. She explained everything 3 times. I never thought it was boring. But nowadays, people say it is boring because you explain everything. But that's not the case. Maybe people in IIT think that way, but not everybody. So I said, what we are doing is the right way to do. Let's get on with it. We started this procedure for IT training. I told you that we trained 7 million students using these. Then I came across a doctor, Rupal Dalal, who said, can we extend it to health training? So we got onto this. And then, in fact, we created close to 100 tutorials, more about it shortly. And then we also said that we should dub this because people are not necessarily fluent in English. In fact, I studied in Tamil medium all my school, and when I went to IIT Madras, I had a tough time speaking even one English sentence. Okay? So I'm very passionate about this. For people not fluent in English, translation should be easy to understand. It is not to promote languages, but to promote employment to people who are not necessarily fluent in our languages. In English, the health spoken tutorials are dubbed into 15 languages. So here is a script, for example, in C++. We write the script, as I told you. After we do the recording, we time the script. Every sentence is timed, and then each sentence is replaced without changing the time. You can see the same thing in Hindi now, and then I can juxtapose. You can see the English and Hindi, English and Tamil, English and Urdu. So you can put them all together. So the video is made only once. Only the audio part is changed. You have to give voice to the script and then just attach the video and the audio.
गर्भवतियों के लिए शाकाहारी खाना बनाने के तरीकों पर बने स्पोकन ट्यूटोरियल में आपका स्वागत है। इस ट्यूटोरियल में हम सीखेंगे
ಕ್ರಾಡಲ್ ಹೋಲ್ಡ್ ಫಾರ್ ಬ್ರೆಸ್ಟ್ ಫೀಡಿಂಗ್ ಸ್ಪೋಕನ್ ಟ್ಯುಟೋರಿಯಲ್ಗೆ ನಿಮಗೆ ಸ್ವಾಗತ. ಈ ಟ್ಯುಟೋರಿಯಲ್ನಲ್ಲಿ ನಾವು ತಾಯಿಯು ಮಗುವಿಗೆ ಹಾಲುಣಿಸಲು ಆರಿಸಿಕೊಳ್ಳಬೇಕಾದ ಸರಿಯಾದ ವಿಧಾನ.
வணக்கம். கால்சியமின் முக்கியத்துவம் குறித்த ஸ்போக்கன் டியூட்டோரியலுக்கு நல்வரவு. இந்த டியூட்டோரியலில் நாம் கற்கப் போவது நம் உடலில் கால்சியமின் பங்கு.
I have in couple of other languages also. I have one in Sindhi, one in Spanish.
थाणा जो खीर प्यारण वास्ते क्रॉस क्रेडल होल्ड जे स्पोकन ट्यूटोरियल में तवांजो स्वागत आहे.
Bienvenido al tutorial hablado sobre la posición de cuna cruzada para amamantar. En este tutorial vamos a aprender a elegir la.
So I already told you about this. If lots of people have to stream, then there is not enough, big enough pipe. So we make the tutorial suitable for offline use, and usage in IT increased 100-fold. Okay? In fact, on our website, you see about 100 million page views, but many of them, after they download, are used by hundreds of people, and those numbers are not counted. So the actual views are many more. I would say that our health spoken tutorial project would not have been successful without the offline version. Use of health spoken tutorials is going up, is growing. Nandurbar, which is a tribal district in Maharashtra, more about it shortly. Bardoli in another tribal district in Gujarat. Ahmedabad Municipal Corporation, Uttar Pradesh ICDS, Integrated Child Development Scheme. They are all using our health spoken tutorials. You saw glimpses of that in various languages. In fact, this organization is also in the process of implementing it, at least evaluating it for use in Chikkabalapur. And we are also discussing with the Karnataka government. And there are many more in the pipeline.
सभी वीडियो मैंने देखा है वो वीडियो करते ये वीडियो सबसे अलग है और ब्रेस्ट फीडिंग देने में बहुत सहायता करता है। मैंने पहले भी वीडियो देखा है पर वो वीडियो में हम जे पद्धति के ले रहे थे बच्चे को वैसे वो बच्चे फीडिंग नहीं ले पा रहे थे और अटैचमेंट नहीं हो रहा है। मैंने आप क्रॉस कैडल आप सिखा रहे हो जे वीडियो में वहाँ हम बच्चे को रखते हो तो बच्चे और माता का संपर्क बहुत ज़्यादा रहता है और फीड अच्छे से ले रहा है और वो जो मुंह खुलता है वो बहुत ज़्यादा खुलता है और फीड बहुत अच्छे से ले रहा है। और ये सब वीडियो है हम दर्दी को समझाते हैं और दिखाते हैं गुजराती सभी गुजराती में दिया है तो सरल भाषा में पेशेंट और पेशेंट के सगे वाले भी सरल भाषा में समझ जाते हैं और हमको भी बहुत
Okay. I have 2 more minutes. I'll just briefly summarize some of the other things that we have been doing. Nandurbar, I already mentioned. It's a tribal district in Maharashtra, adjacent to Gujarat. 85% of mothers claim exclusive breastfeeding. Very high, but very high incidence of malnutrition. So, in fact, this collector, Nandurbar's assistant collector, says the following. I'll give the link for her story at the bottom of this slide. From their observation, a newborn normally gained about 10 to 12 grams a day through exclusive breastfeeding, whereas our National Nutrition Mission guidelines recommend 28 grams weight gain per day. So the actual is much less. But using our method means we teach them how to do breastfeeding. I have a Dr. Rupal Dalal, who is an expert in this and more importantly, very passionate about it. She's the one who helped create all these tutorials using our method. And using that method, the ladies learn, mothers learn, and they have seen 35 to 40 grams of weight gain and even 50 grams per day. So here is a link. Thank you. Thank you. So here is a link for the story. It's available. You can look at that. In fact, the district collector is talking to our Honorable Prime Minister. She got an opportunity to present to all the principal secretaries, about 200 of them, all IAS officers, senior IAS officers, chaired by the Honorable Prime Minister. Converted to problem solving with the help of software Q-Tree. Basically, there is a lot of material. They go through this. When there is a problem, it is difficult for them to figure out where they have to go and see. So we have the script. The software will immediately say that, things like, okay, the baby is not gaining weight. Okay, is the mother giving milk regularly? Yes. Then maybe she's not doing it effectively. So it will take them to the right video at the right location so they get to see that. That's what I meant by converted to problem solving. And you can do this for any other problem as well. Problem solving document is there. I'll skip it. The next one I told you that we can massive blended training. Idea proposed from teacher training. Basically, this is the teaching hub and there are remote centers and We train one person from each of these centers through a contact mode. They become good enough, they go back and help conduct in a massive way through a distributed learning methodology. We called it T10KT, train 10,000 teachers. So we do a pilot workshop for that, validate the instructional material, then the coordinator workshop wherein one person comes from each of the centers. The trainers get trained, the massive workshop happens. Remember, the final learning happens through spoken tutorials which are guaranteed for self-learning. So they become only facilitators. So there is no loss that normally happens in train the trainer program. Okay? So these are some examples. If you have 50 people and then 100 centers, then you have 5,000 people trained. And then we address all the centers live, explain the workshop procedure, and then the trainers conduct training in each center, and the learning happens through spoken tutorials. And we clear doubts of all at regular intervals. Is this approach working? We conducted several IT training methods using this. All this happened before the pandemic. These are all IT topics. Okay? So these are centers where these workshops happen. So I claim in this slide that it is possible to scale up health training also. If not in critical ones, at least non-critical ones, that you can scale it up in a big way to start with. We validate our procedure and then we can go on. To conclude, affordable healthcare is the need of the hour for many. Number of healthcare providers also has to be increased tremendously. Technology-based education can help achieve the above two, at least in non-critical areas. Will definitely work in the area of preventive healthcare. So our project is funded by private donors. We are in need of more donors. Thank you.
Kanan, we in medicine are used to have one subject, which is infectious disease. You have shown us that there are other kinds of infectious for promotion and education in medicine and to reach to all the people. Thank you so much. Next speaker, we have the pleasure to introduce Dr. Vasudeva Upadhyaya. He is the head of the Department of Anesthesiology here at Sri Sathya Sai Memorial Hospital. He shall present on the topic, Incorporated Integrated Medicine into General Practice and the Current Medical Curriculum, Challenges and Solutions. Thank you so much, Doctor.
Sadar pranams at lotus feet, respected dignitaries and delegates. Good morning to everyone. The topic is incorporating integrated medicine, current medical system, problems and solutions. I have limited time. My time has been reduced. The talk time, not my time. The talk time has been reduced. So I'll try to, see how I can manage. There are no conflicts of interest. There are no financial supports for this. From the Almighty, it is there, of course. So I submit it there. Droplet, I have got information. There is an ocean of information to tell you. That the only thing is that I am aware that there is an ocean. That is great, and I am thankful for that. It's a vast topic, and time is very limited to share with you. So what I will do is try to uncover a little bit so that you will become inquisitive. I am here anytime any of you can call me or email me, and we will share the information. We can discuss a lot for days or years together. There are lots of conflicts, and it is unfortunate they are highlighted and they are spoken about rather than what is there which we can use and which we can make beneficial. So I concentrate there what we can use and only identify the problem to see that we find a solution for that. This is just an example how the system is in cycles. Okay, so first you started taking root for a disease, and then we say prayer and then take, and then we drink a potion, then swallow a pill, then antibiotics are discovered, and COVID has shown that these antibiotics are no longer effective, we are back to roots. So this is how the system is evolving in cycles. What are we, first when we want to identify the problem, we must know what we should be doing and what are we doing. Are we doing what we are supposed to do? Hippocrates in 500 years BC said, to cure occasionally, relieve often, and to comfort always. This is long back, 2,500 years back. Then the advent of antibiotics, anesthesia, asepsis, doctors thought we have conquered all the diseases and they started concentrating on cure always. But where are we? 80% or 90% of the patients who come to the hospital are not cured. They are given symptomatic treatment, diabetes, hypertension, so many things, ischemic heart disease. We don't have a cure. We just treat the symptoms and send them back. Except for some small, infectious diseases, especially bacterial and surgical conditions, we don't have cure for most of the things. But in the process, we have forgotten that we must comfort always. We must be compassionate and we must try to relieve as much as possible, but we are not doing it. We have forgotten that. Then, what else we should be doing? We should be doing health promotion, disease prevention, improve disease-bearing capacity, and then cure. But what are we doing? If we read the medical curriculum, more than 80 to 90% of our curriculum consists of, I am sure all doctors here agree, we are taught, we have got so many things to identify the disease and treat. We don't have much to see that the people are healthy and they don't become sick. So the concentration and focus is on treating the disease rather than health promotion. I think we need to change that. And what is the basis? The basis is ethics, 4 pillars of ethics. Respect the autonomy of the patient, do good, do no harm, and be fair to the patient. To do good and to do no harm, what should we be doing? We should be knowing what is harmful and what is beneficial for the patient. How much do we know? I was asking, I am from a medical college, so I was asking, there was a different, strata. Like here we have on one side a wide spectrum of audience, experts, international experts, we have policymakers, and we have budding future doctors, many of you. So I am keeping that in mind and trying to put it across. I should be aware what is beneficial and what is not harmful. But how much I am aware, if you ask me, this tells me. Okay. We are ignorant. We don't even know that we are ignorant. That is the basic problem. I don't know. The moment I realize that I don't know, majority of my problem is solved. At least I will start seeking for a solution. There is a parable, 6 Indian men and an elephant, blind Indian man and elephant. We are in the same situation. Sadguru was telling us few days back that when you make sambar, he still calls me drumstick, okay? So if the drumstick says it is me and holds on, if the potato says it is me and holds on, and if the dal says in me and holds on, and they all remain individually, can you eat that sambar? Can it do good for you? The answer is no. What should be done? He said each one should give something to the sambar. It is not only that each one should give something to the sambar, we must absorb something. If I am drumstick, I give my flavor, and I also observe some flavors and spices from the sambar what is put. Then I also become tasty, sambar also become tasty. That is the need of the hour. That is what we should be doing with regard to medical system. Allopathy is there, Ayurveda is there, yoga is there, so many systems are there. I have put it in a nutshell. I think this describes the problem and the solution. And actually, if you ask me, if you understand this, the problems and solutions are over. Then, why I am ignorant is because in my training program, I learned Greek and Latin. He said Sanskrit word should be learned and there is a separate lab. I learn profunda femoris, but I don't learn what is there in my culture and system. That is very unfortunate. Many of my friends and colleagues say mixopathy and they say it is nonsense, it is non-science. But when I ask them, they have not even heard of Charaka and Sushruta. the land from where we come. It is very unfortunate, and if you start reading, it is so scientific, but we don't know. We have got a very strong biased superiority complex over the West system. Nothing offense meant here, and we have got a biased inferiority complex. So what should be done? Change. What is the inspiration for change? Necessity. Necessity is the need. What is there? It is not that I am inventing something. Punarapi jananam, punarapi maranam, punarapi janani jatre shayanam. All these, our systems are sleeping in the stomach, womb of the mother. We have to wake up, we have to deliver, and we have to make them grow up like Shankaracharya, what he has said. Then I think the system will become beautiful, it will get its answer. Mahatma Gandhi got us freedom from slavery, and he said, experiments with truth. I am not so big, I have got a very small experience with truth, so I will share one or two things which, if it inspires, my purpose is served. Necessity, I said, is the mother of invention, and that is what brings in change. So how do we bring that? I started pain clinic in the institution, which is a medical college. I worked there for 27 years. 2000, I started the pain clinic. I am junior. Patients are treated by expert senior professors, and they don't have a remedy. They send their patients to me. What do I do? Do I have a remedy? My patients knew much more than me. I am shamelessly admitting that. Okay, whenever I suggest something, sir, adella agogbitide. Adella esto sari tagondbitidini. So that was my situation. So what do I do? What do? I start exploring, I seek change. Thanks to my brother, one of my brother, when I was a small child of 10 years, he had herpes. And then it is God's grace that I still remembered. And when my patients with herpes is a disease where it is like you keep an iron rod on the body, how it feels. And patients can suffer for months. If it comes for ladies, it comes on the chest, they cannot even wear the dress. And so they cannot go out, they cannot come out of their room. So that is the state of condition. And for that we have only unscientific treatment I am not downgrading my system. I am just saying what are the problems so that I can address it. My system is very good. There is no problem as such on an average if you take. I chose it and I like it and I love to still practice that. So I found this, 80% of my patients had 100% pain relief with this simple leaf. Then chikungunya came. And it was a chance, it is not written, at least herpes, this treatment is written in some traditional books. In fact, I went to FRLHT, that's a central government institution. They have got 7,000 plants, herbarium, but they didn't have this plant. I made the herbarium, gave them the details. And then for chikungunya, this treatment is not described anywhere. People give steroids, painkillers, and so many things. It was a chance finding from the divine grace I got this. I started, thousands of people have been treated with this, and within 1 week, they are completely free from pain from chikungunya. They stop all their analysis. Thank you. That shows that whether we should integrate or not, how you feel. And then further, what I do, it created so much of inquisitiveness in me, it exposed my ignorance, so I started studying. In fact, I have at home more Ayurvedic books than my anesthesia or allopathy books. Not that I am not reading, I have got all the latest journals of anesthesia also. People come, ask me with God's grace that you please come and give anesthesia for me or for my patients. When the surgeon comes and he has to undergo surgery, if he asks me, that is the biggest compliment for me, and I am fortunate for that. So I started studying and I started meeting people with the other systems. I interacted to ask them how the elephant looks like, and I have given one example. This is a surgeon. This patient which I have put is a beautiful example for integration. He has used our anesthesia, he has used our diagnostic tools. This patient has undergone, I think, more than 15 surgeries by allopathy doctors, and with one surgery, he cures this patient. He is fine. It is about, I think, more than 5-10 years. And this is published where? In one of the top international American journals. He was invited there and asked to give a talk. He is an Ayurvedic surgeon, and when we say Ayurvedic surgery, we think it is mixopathy and nonsense. That is very unfortunate. Then evidence-based practice. So I got 3 more minutes. And allopathy, modern medicine, I am very happy that I am an allopathic doctor. I took it by choice. I would have got into any systems, including engineering. So it is peer-reviewed, etc., etc. I don't want to talk too much about it. There are some ills also, which I have already put it. All of you know about it because whenever we have this debate, they talk about it. But what I want to say is, he has already told a little bit, Ayurvedic system is also a pure science. There are Ashta Pramanas, Dasha Pramanas, Dwadasha Pramanas, proofs. What is the proof? Shankaracharya has told very beautifully, snake and roe parable. You see something moving, you see the hood in the dark and you think it is a snake. You are telling lie or truth? You are telling truth. But what is the fact? Fact is that when you put the light, you realize that it is not a snake, it is a rope. Same thing, like sunrise. If I ask you where does the sun rise, I am sure more than 90% of you will say sun rises in the east. But does the sun rise in the east or is he relatively stationary? That is evidence that is described in Ayurveda. So I don't want to go too much about it. Anyway, whether it is safe, it's very important to realize this because people say it is safe, I took and I became sick. Nothing is safe, whether it is Ayurveda or allopathy. To give an example, if you take honey in a very hot day after a hot bath and if you put it in hot water, you can die. Honey is so good, so natural. Same way, paracetamol is considered safe drug and over the counter it is available, but the commonest cause for drug-induced hepatotoxicity in US is paracetamol. Regarding research, he was mentioning we employed biostatistics, etc., etc. ICMR wants for COVID, what is the molecule, what is the receptor? No, it is not correct. If you try to see what is there in the onion by peeling, what do you get at the end? You don't get anything, you get nothing. So you cannot apply the same parameters when you want to do research. So in our medicine, we use what is called molecule receptor theory, reductionist theory. In alternative medicine, it is what they call it reverse pharmacology. You give the drug, whether patient feels better, then if you go searching for what is the cause. So that is reverse pharmacology. Then coming to the core issues, you identify the best in each system. You create an expert pool. I'll take just 2 more minutes. And unbiased validation. And then final common path is not whether drug, see one drug they gave it for COVID and they said it's very effective, but after 3rd day patient developed severe sepsis and died. The drug, some people have even paid 3 lakhs per dose. I don't want to mention the drug. Is it correct? On the other hand, so many people got churnas and they became all right and went home. So final common pathway is not whether the drug improves saturation, whether patient is healthy or not. So quality assessment, this is where our technology, we can use it so much. You create a national database. Now they are making national health card. Create a registry, anonymize the data, put it onto artificial intelligence. That will tell you whether you must take some churna or something or some, new drug which is imported and costs in lakhs or crores. Set standards. So this is, we can make use of artificial intelligence and we can do. So create a strong database, create an integrated curriculum, standardize it, revalidate it, train the trainers and introduce the course. There is no shortcut, there is no quick fix solution, there is no bridge course. That is all nonsense if you ask me. If you want science, this is the way we must go. Addressing most of the talked about will become redundant if you do this. And then what should we do with the existing system? Pure science should be there. We must study because lots of things are unexplored, especially in Ayurveda, yoga and all. It is very often misinterpreted according to our own present understanding, but what is there is something immense. So we must keep that. And existing practitioners, they should undergo training to have awareness, that's all. And if you want to practice, you undergo the total training and then practice. Otherwise, it will become mixopathy. Then, please don't go to the next slide. This, I want to keep it as the last slide. Next one is made summary for a different reason. So this is what our Indian culture says, the total health. I think most of you are aware, otherwise you can just go on the internet and see. As Sadguru said yesterday, Ano Badra Kravanto Yentu Vishwato. Let knowledge come from everywhere. And then, what should we do? Only one sentence for my conclusion. It is not that when we have a hospital, hospital is full and I am successful. Hospital, if I am a successful doctor, hospital should have no patients. Everyone should be healthy, and what is my duty as a doctor is to see that the people are healthy and they don't get disease and they don't come to the hospital. If Chikbalapur hospital is empty, people like Vishweshraya lived here for 100 years. If they live for 100 years without any deficits, that is successful medical practice, that is need of the hour, and I am sure people sitting here at the back can make it. I will walk in at 100 years to the Mudenhalli hospital and I will be the happy man. Thank you.
Thank you so much, Dr. Vasudeva. Being one anesthesiologist and your field is to relieve pain, you have shown us that the most use whatever is useful for the patients and not one single system of medicine. Thank you so much. Right now, we have the pleasure to introduce our next speaker, Dr. Hiramalini Shashadri. She has both roles here, speakers and co-chairs. She has a lot of roles. She's a senior rheumatologist at Sri Satya Sai Sarla Memorial Hospital, and she will speak on the topic, the need to promote respect for traditional system of medicine in the medical curriculum.
Shri Gurubhyo Namaha. Co-chair Dr. Bera, fellow speakers, Dr. Rajgopala, Dr. Kannan, my colleague Dr. Vasudev, distinguished guests, fellow doctors, and very dear students. Namaste to all of you. The topic that I will speak on today is the need to promote respect for traditional Indian medicine in the medical curriculum, a historical perspective, and a current research update. In 2011, there was a landmark study that was published in the journal Psychological Medicine, Psychological Science. There's a strong positive relationship between feeling good about your country and feeling good about yourself. If you feel good about your country, you are inspired, you are fearless in your thinking, even think out of the box, and you're able to contribute positively. But if you feel ashamed of your country, your culture, your traditions, it results in a fear to lead, a fear to take the initiative, in a what will people think of me mentality, a slavish mentality. And so, okay, he's trying to sort out the slides. I'll give you a few examples while he's doing that. You will all agree that yoga as a practice is an Indian idea, Indian concept. Meditation as a system for total health is an Indian idea, Indian concept, Indian practice. And the idea that karma may be in some way responsible for the pathogenesis of disease is again an Indian concept. So, who should be researching these ancient Indian concepts of health and disease? It should be Indian doctors, right? But who has done the research? 99.99% of research in these areas has been done in the West. In fact, reincarnation has been studied by the University of Virginia for the past 50 years plus. Why did we lose out like this? I'll tell you why. It was in 1820 that modern medicine was first introduced to be taught in India. And at that time, it was truly integrated medicine because they were taught modern medicine, Ayurveda, and Unani. It was fine. But in 1835, Macaulay came on the scene and he banned the teaching of Indian medicine. He banned even the use of Indian languages. So for 3 centuries almost, Indian medical students have been programmed to subconsciously believe that anything Indian or traditional in medicine is inferior, unscientific, primitive, and needs to be shunned. So even after independence, for 75 years, we Indians have Indian modern medical academia, unfortunately, has had a mental block to accept anything traditional in our traditional Indian medicine or to even study or research it. But the world today recognizes traditional Indian medicine. The Global Center for Traditional Medicine is in India. And we must remember that 70% of rural India still uses traditional medicine because it is available, it is affordable, it is acceptable, and it is acceptable because in the doses that it is generally given, it doesn't have much adverse effects, and most importantly, the practice of traditional medicine is anchored in connectedness, spiritual connectedness, and socio-cultural connectedness. Modern research has proved, last year we had a paper on this at this very conference, connectedness itself heals, irrespective of pharmacological or therapeutic variables. And this is why sometimes traditional medicine seems to be absurdly effective, much more than our rational expectations, you see? And this connectedness is sadly really missing in modern medical practice. Talking of pharmacology, 90% of the new modern medical formulations are derived from traditional medicinal herbs. Now, thanks to the internet, people know this. So even in the developed countries, 35 to 70% are opting to try out traditional medicines. And our medical students need to know this because they need to be sensitized to our traditional Indian medicine, and then they will take pride in our medical heritage, and in future, they will be inspired to combine judiciously the traditional and the modern and develop true integrated medicine. In China, it is modern medical academia that has fostered the resurgence of TCM. And today, a TCM researcher has won the Nobel Prize for Medicine. India needs to do a China. But is our modern medical academia ready for it? Good news is things have started happening. Right here in Bangalore, we have at least one academic medical institution with a Department of Integrated Medicine, and that is NIMHANS. Now, you've listened to an expert on Ayurveda, my brother, Dr. Rajgopala. Ayurveda is the most well-known of the traditional Indian medical systems. I will restrict my talk to the Siddha system of medicine, historical perspective, and current research. The Siddha system is not as well known as Ayurveda for 3 or 4 reasons. Firstly, its practice is largely restricted to South India, to Tamil Nadu, Kerala, Karnataka, and Andhra. And the senior traditional Siddha physicians, traditionally, they talk less, they do more, okay? And they are all more comfortable in their own languages and not in the international medium of communication, that is English. Also, the traditional Siddha texts are still mostly in palm leaf manuscripts still, and this is written in ancient Tamil or in Grantha, and very few people are trained to really decipher and interpret it. But there is an exponentially growing interest in practices of Siddha medicine like Kriya Yoga and meditation, and in Siddha remedies in the West. So in 10 to 15 years, definitely Siddha system of medicine will be much better known. Okay, so how ancient is the Siddha system? According to a 2011 paper by Professor Saraf from Raipur in the journal Systematic Reviews in Pharmacy, it states, Siddha is possibly the oldest known scientific medical system on the planet, 4,000 to 10,000 years old, possibly more. What is the evidence for this? According to modern historians, Indian historians and international, a great maritime Vedic civilization existed in peninsular India, which extended 10,000 years ago, far beyond the present coastline, and Siddha medicine flourished there. What's the evidence for this? We have scriptural, literary, epigraphic, oceanographic, and geological evidence. Now, what happened to that land? It has been proved scientifically now that there were sudden rises in sea level, cataclysmic events like tsunamis, and according to the National Institute of Oceanography and the University of Durham, India lost close to 1 million square miles of land to the ocean. What is the evidence that there was a great civilization there? As I said, all those evidences, and the clincher is this. We have found submerged artifacts in the deep ocean. First, they found a structure which was 11,000 years old, a man-made structure off the coast of Tamil Nadu. And in 2020, current science reports that an entire harbor was found, more than 30 kilometers off the coast of Tamil Nadu, 80 meters below the surface of the sea, and this is supposed to be 15,000 years old. So there was a great maritime civilization, all right. What happened to these people? When the waters rushed in, they fled. They came northwards, and these are the coastal states of India today. Some went up the Arabian Sea and into the Saraswati River, which was flowing in those days. They set up the Saraswati River Valley civilization. Some went west into Sumeria and set up the Sumerian civilization. This is a current theory that is gaining ground. So we can take pride that we are the scions of such a great civilization, and the Siddha system of medicine is a product of this civilization. Now, was the Siddha system advanced? Let us look at their knowledge level. Millennia ago, the Siddha physicians spoke of unir, that is plasma for growth and nourishment. West knew it only in the 19th century. They spoke of chennir, which gave the red color to blood. It nourished muscles. It was needed for energy and strength. The West knew it in 17th century. They spoke of un, or muscle, that gives shape to the body. They spoke of elimbu, or bone, which is responsible for structure, for posture, for movement. They spoke of korupu in the joints, which helped in lubricating the joints and movement. And they spoke, very important, of elimbu majjai. What's that? Bone marrow. And they said that this was where the elements of blood are formed. Now, this was knowledge that the West knew only 2 centuries ago. So it is very high on knowledge. And today we're having this conference on medical education. Recently, it has come to light that there was a medical school set up by Siddha physicians. According to the Siddha literature, Agastya, Vaidya Shekharam, and other palm leaf manuscripts, I found one by the late Dr. Mandayam Kumar, who spent an entire lifetime translating these manuscripts. There was a Toranamalai Institute of Medical Sciences. Now, where is Toranamalai? It is in the Tenkasi district of Tamil Nadu, and there is a Toranamalai research group as well. When was it set up? In the Siddharthi Samvatsara, the 53rd year of Kali Yuga. See, our ancient astronomers were very, very good, and so we can calculate timelines pretty well now, okay? And 53rd of Kali Yuga means as early as 3049 BC. That's, say, 5,000 years ago. Probably the oldest medical school in the planet. Who set it up? The great Siddha physician Agastya, along with Bogar, who was from China, Yugumani from Kerala, Nandi Deva from Malaysia, and other great Siddha physicians. And they followed the Gurukula system of education, no fees. And that is exactly what our most revered founder, Sadguru Sri Madhusudan Sai, wants to do here. Establish a residential medical college with absolutely no fees. And how was candidate selection done? Based on some eligibility criteria and aptitude, not on commerce. They followed a rational syllabus. So says Agastya Vaidya Shekharam. The 6 years was a basic course, and they taught Ogam, that is the Tamil word for yoga, and meditation. This was a foundation course, continued throughout their education. Then they had their own basic and clinical sciences. Then further 6 years of study in various disciplines, and another 6 years of maybe what we might call post-doctoral study. Thereafter, many of them took to the Jnana Marga, took to intense yoga, dhyana, and became perfected men. They apparently learned to exist in more than just the physical. They knew how to move into the subtle dimensions. And then they took on what they call Jiva Samadhi. They were walled off, even as they were alive in the body. And they attained immortality or paramukti. Due to paucity of time, I can't discuss this fascinating science with you. But it is an astounding fact that even today, traditionally trained Siddha physicians who are adepts in meditation, can connect transdimensionally to the great Siddha physicians of yore. Why? For a second opinion. Even guidance on treatment of patients. You and I may not believe this, but the West is open-minded. They are studying this. We have the Institute of Noetic Sciences in California, headed by Professor Radin, who's studying the potential abilities of human beings. The Western defense establishments are studying this. And with the help of Sadguru of Isha fame, many Western universities and medical schools are studying Kriya Yoga and its benefits on health. Scientific medical techniques were taught. They were taught physical examination, examination of the eyes, the mouth, the tongue, the faces, mental state examination, the gait. And they used the pulse to diagnose illnesses, just like the Tibetan system. What about investigations? They tested the stool and they tested the urine. What about the medicines? They had oral preparations, inhaled preparations, topicals, medicine and oils, and even parenteral injections called Rajavaidya. They did a lot of research on snake venom, tried to make medicines out of it, something we are researching now. And maybe inspired by the fangs of the poisonous snakes, they developed syringes and long, hollow needles made of copper and gold alloy. Subsequently, in Ethiopia and Chinese cultures, they've been using this. They used scientific principles of surgery. Dr. Vasudev might be interested. Millennia before Christ, they knew about hand washing, disinfection, sterilization of instruments, how to give local anesthesia and general anesthesia. They used banana fiber and silk as suturing material. And they even experimented with transplant surgery and plastic surgery. They had specialties like ophthalmology, oncology, bone setting, pediatrics, even psychiatry. They had a very good understanding of health. They would say, unave marundu, which means food actually is medicine. And they knew the importance of mental health and how it can affect physical health. Hippocrates said the same. And very uncannily, the Siddha Oath is very, very similar to the Hippocratic Oath. And I must share this very significant aside. It is said that on the instruction of sage Dakshinamurti, who is believed to be an incarnation of Shiva, the Siddha physicians recorded all the knowledge of the day into palm leaf manuscripts. When does this happen? In 3089 BC. All the learnings, it's there on the slide for you to see, and this included all the Siddha medical knowledge and Siddha ethics. And later on, this was translated into the 4 great languages of the world then, Sanskritam, Chinese, Hebrew, and Greek. So what does this imply? Long before the time of Hippocrates, the ideas of Siddha medicine were translated into Greek. We know that the guru of Hippocrates, Democritus, was influenced by Indic thought. So also Heraclitus. So though we lost our records and monuments because of the oceans invading our land, survivors carried this knowledge with them. And we're finding these palm leaf manuscripts now and then, nowadays. It's my humble hypothesis that the medical knowledge, including ethics, compiled by the great Siddha physicians, later translated into Greek, influenced Greek thought and found expression millennia later through Hippocrates. Now let's move on to 20th, 21st century. Fast forward. Do Siddha medicines work now? Yes. Professor Devanayagam of Chennai has published papers on the effectiveness of Siddha remedies in HIV and AIDS patients. During the epidemics of dengue and chikungunya in Tamil Nadu in the 90s and early 2000s, we found Siddha medicines very effective. And today, during the pandemic, we know that Kabasura Kudanir is effective in COVID-19 for prophylaxis, as a cure, and to prevent the cytokine storm. In fact, Kabasura Kudanir has been recommended for pan-India distribution by Ayush. Meditation is a vital part of the training of Siddha physicians. The Roswell Cancer Center states unequivocally, meditation helps patients. 3,000 plus studies show meditation is effective in depression, in hypertension, in autoimmune diseases, allergies, asthma, even cancers, because the telomeres don't shorten, and so on. Okay? Now, meditation helps doctors. There's a landmark study in JAMA 2009. Doctors who were put through 1 year of meditation had better health, less burnout, and improved patient care because they were more empathetic, had more compassion, and they were less stressed out. And Harvard study 8 weeks of meditation produces favorable changes in brain function and structure. Gray matter improved in 4 vital areas: left hippocampus, posterior cingulate, temporoparietal junction, and the pons, areas responsible for learning, for memory, for cognition, for judgment, for compassion and empathy, and the amygdala, which is responsible for fear and anxiety and aggression and anger, actually shrunk. And all these doctors had much less stress levels. So, should we not put our medical students through a course of meditation? Should they not know something about this? And one can go on and on. But the takeaway is this: it is time for change. To introduce and sensitize our medical students to our rich medical heritage so that they can take pride in it. And then they will do the research and produce and add the best of the traditional and the modern and lead us to true integrated medicine. Students, this is your job. And they need to know about the great physicians of India, like Agastya, the all-time great, the most illustrious predecessor of Charaka and Susruta. And we'll be hearing more of him as more and more palm leaf manuscripts are getting translated. It's wonderful if the NMC responds positively to these suggestions. And now, as they would say in a court of justice, I rest my case. Thank you and namaste.
Thank you so much, Dr. Hiramalini. Thank you for giving us true facts about the history of Siddha medicine and the use of it in current times. Just one comment. I'm a pediatrician and family doctor from modern medicine, working on Ayurveda, not Ayurvedic physician. But really, all of the people here on stage has years and years of work and passion for their work. And this is a national conference on the education, the need of reforms in the medical field. And then we, instead of doing a summary of each of your speech, we want to ask you, 1 minute each of one if it's possible, 2 main suggestions in order to implement for the future is the medical suggestion. 2 minutes? 2 suggestions, yes. Two suggestions related with actions to take in consideration for in the field of medical education. Dr. Rajagopala, please, you will.
Thank you. I have already told, from contradiction to complement. We should not contradict each other, we should complement each other. The medical systems do this. From this or that, allopathy, Ayurveda, Unani, this or that, to we have to have this and that. That is the need of the hour. The best of all systems should be pressed into one package, that is integrative medicine, and leave our egos away, and we should work for the Vedic Upanishad wordings, Sarve bhavantu sukhinaha. The second line is more important, Sarve santu niramayaha. Let us do together, go together for good health of all. Thank you.
Actually, the idea is very simple. Use technology to make the education reach everybody. Let it be accessible to all of them, anytime, free of cost.
Heal the diseased medical system. I think that summarizes everything. Thank you.
I will speak for Dr. Mimi, Guarneri, and me. For Dr. Mimi, it would be, in the USA, the need of the hour is integrative medicine that includes incorporating the best of traditional medical systems of the world, inclusive training program for all health workers and not just doctors, and a Heal the Healer program because there's so much burnout there. As far as Indian medical education is concerned, from my part, the need of the hour is to get over the colonial mindset and to sensitize medical students to traditional Indian medicine so that they develop pride in our medical heritage, and they learn about the role models like all-time greats Agastya, Susruta, Charaka, and so on. Besides integrated medicine, we need to go back to our roots, and in keeping with our traditions, we need to decommercialize medical education as well as healthcare as it used to be in traditional medicine in our country. Thank you.
Thank you so much, Dr. Hiramalini. I just want to say we have not to have fear about the integration of medicine. The people need the integration of medicine, and if we have the miracle here to have a school of medicine here in this place, I think it's very useful to think that it's much more easier if we began the School of Medicine having this point in consideration and not to add in other moments. That's other suggestion. Okay, thank you so much to all of you for your being here. Thank you for all the speakers. Really, the medical field needs change. The people need better health. The people need better medical doctors. The people need better health team. And we hope that this session will help to have these points in consideration for the future. Sai Lakshmi.
There's one more thing. There is going to be a Veda Conference in a day or two, and one session of the Veda Conference will be dedicated to Ayurveda.
Yes.
Just for your information.
Thank you. In the Veda Conference, we will have the presence of the Secretary of Ayush, Dr. Rajesh Kotecha. Also, the presence of Dr. Mita Kotecha. She is the Pro-Chancellor of National Institute of Ayurveda. She will speak about the scientific information of the medicinal plants used in Vedic ritual procedures. Also, Dr. Tanuja Nesari, the Director of All India Institute of Ayurveda, and Dr. Manoj Nesari speaking about Ayurveda and Ayurgenomics, and I will speak about principles of Ayurveda. Thanks for reminding that. Thank you.
Thank you, session chairs, panelists, and delegates. I'm sure this session was extremely fascinating and interesting to all our students as well, and all of us enjoyed it thoroughly. Thank you very much. May we now request our session chair, Dr. Bera, to hand over a token of our appreciation to our panelist, Dr. Rajgopala. And we request Dr. Hiramalini to hand over a token to Dr. Kannan Maudgalya. Request all our panelists to kindly come for a group photo, please. Thank you all. With this, we close session 3. We'll have a short break and reconvene at 11 o'clock for session 4. Thank you.